All right, so this is going to be the MEC 2024 MEC Minute, and the topic is one of our favorites, and that's lift assists. For those of you with good memories, I've given this talk in the past, but I thought it's time to really talk about it again. We've had a good number of new providers join us, and recently we've had a couple cases where lift assists resulted in non-transport in patients who then had a callback for EMS care with not particularly great outcomes. So we're going to talk more about lift assists, which again is everybody's favorite topic. So when we do this, what are we going to talk about? And there are four questions for discussion. What is a lift assist? Why is it important? What should our assessment include? So it's not just getting the patient off the commode. It's what do we do to assess the patient to make sure it's appropriate and safe to leave the patient at home? And then we also need to talk some about who can stay home and who needs to go. And how we can leverage our position if the patient's reluctant to go, but you think they do. So we're going to start off with a case. So first is a case, it's a 2 in the morning case. Engine 1001 is sent on lift assist. And the comments on the MDT is that the patient needs help off the commode, and you're going to an independent living facility for the elderly that is entirely independent. They have no resources available for the elderly. It's not assisted living or any other type of organized care. On your arrival, EMS is led into the apartment by a neighbor. She happens to have a key. The apartment is hot, cluttered, the sink is full of dirty dishes, and the patient's sitting on the commode. She's awake, alert, and interactive. She states she is normally able to care for herself, but for some reason she cannot get up off the commode this morning. So think about that. Think about this case as we go through the slide deck. So first, what is a lift assist? And, we think of a lift assist as somebody who needs help. Dispatch message comes out as a lift assist. But there's actually been some thought and talk about what is a lift assist and how might you define it. So one article in Pre-Hospital Emergency Care identified a lift assist as an individual is assisted up to a more mobile position from the ground by paramedics, but not treated or brought to the hospital for further attention. So if you look at this definition, a lift assist is somebody's on the floor. It really doesn't cover those patients who are stuck on the commode or in some other circumstance where they need assistance. The other study is by Dr. Cohn from the early 20-teens. Dr. Cohn recently retired from Yale. He's a big EMS researcher, and for their purpose, a lift assist is defined as patients who are unable to move from an undesirable position to a preferred one. So if somebody's on the commode, they can't get up. Somebody's in a chair, they can't get up. Somebody slides out of bed, can't get up. Somebody kneels down to get a piece of something off the floor, they can't get up. So basically the patient's in a position that they don't like being in, and they want to get into a preferred position, meaning generally that they're up around ambulatory and in more comfortable status. So for us, what is a lift assist? It really is, at least from my definition, a patient or patient representative calling for assistance with patient movement or daily activities of daily living that is not associated with acute injury or illness, or at least so says the patient. And that's a key component right there. So the patient can't get around for some reason, their movement is impaired, and the patient says they have no acute injury, they have no illness. So, really the onus is on us to determine if the patient has something acute going on where transport is recommended. So, for us, it's not just they can't move. If they can't move or can't get out of a position for some chronic reason and not because of an acute injury or an acute illness. So why is this topic important? Many of our calls for lift assists are for the elderly or the disabled who are struggling to stay independent. Many of us are fiercely independent. We don't want to rely on others, and we want to stay in our home. We don't want to be in a care facility where everything is monitored, even though there may be resources available to help us have a better life. Falls or mobility impairment may be an indicator of acute underlying disease. And, we have to consider every lift assist as a potential medical emergency. And we have to evaluate for an acute illness. So if you look at our procedure and our protocol, which I'll discuss a little bit later, every patient for every lift assist must be assessed. And the level of assessment, the degree of assessment is really individualized based on the patient's complaint. And then what is an appropriate assessment? If the patient stumbled and fell and they scuffed their knees, they may need some help up and vital signs. If they felt lightheaded, sat down on the floor, and now can't get up, that's a different story. Or someone who calls because their aide didn't show up and they need help getting from the couch to the bed. So this kind of gives you, kind of the spectrum. Somebody who's chronically ill, they need a home health provider who didn't show, and they need help movement, or the patient who has some minor accident and they scuff their knees, but assessment doesn't show anything really significantly acute, or the patient has something acute happen and now they're down and now they can't get up. So patients who feel lightheaded and sat on the floor before they fell, patients who went to bed normal, and now they try to get out of bed and ended up on the floor. Maybe they had a stroke overnight. So the assessment is based upon the patient's complaint and the circumstances of the visit. Why is again this important? Depending on which literature you look at, anywhere from 2 to 5% of our EMS dispatches are for lift assists. For those of you that are on the engine companies, ladder companies, I'm willing to bet that you have more lift assists than true fires. So they are very common. One study showed that of all the lift assists, 21% had resulted in ED visit. 11.6% were admitted, and 1.1% died within 14 days of the call. So when I gave you those percentages, all within 14 days. If you look at it, 21% ED utilization rate within 14 days of the first call, that's huge. A 1.1% death rate within 14 days is huge. Typically, we consider deaths within 30 days, 2% death rate within 30 days to be acceptable. So 1.1% is pretty high. And then admission rate of almost 12% in the first 14 days after that first call. That's high too. Again, Dr. Cohn from Yale, he looked at his population, 55% of patients who had a lift assist had an ED visit within 30 days of the first call. And lift assist repeaters accounted for 18% of all geriatric EMS patients and 40% of geriatric transports. This should tell you that this is a high-risk population, particularly in the elderly. A 55% ED visit rate within 30 days of that first contact, first call is phenomenal. And then there's another from London, which is England, maybe a different population, different social services available. Really don't know enough about it. So this group that they survey may be a little different than our population in the U.S., but 40% of elderly fall patients called again within 2 weeks. This is not just generic lift assist. These are patients who fell. 47% of them called again within 2 weeks. So you fall once, you're high risk to fall again. So is the lift assist a patient encounter? Well, the first question, is there patient contact? And so, there was a call for aid. Somebody called, whether it was the patient or a family member or some other care provider or neighbor. So there was a call for help, and there was eye-to-eye contact with the patient. So for our procedure, from our documentation standard, this is a patient encounter, and we will assess the patient and we will document the care that we gave. So again, this is a patient encounter. High risk features. So who do you have to worry about? Actually, you should worry about all of your lift assists, but who should get that special bit of attention? Anybody with abnormal vital signs. Patient's got a blood pressure of 80 systolic. That's not normal. I'm not aware of any adult patients that are normally ambulatory with a blood pressure of 80 systolic. So it'd be hard to convince me that even if the patient tells me that their pressure is normally 80, that we should ignore that vital sign and consider it normal. Any acute changes from baseline, that's very important. So if the patient was normal last night when they got into bed, normally can get out of bed without difficulty, and today they slid out of bed, landed on the floor, those patients are significant risk, and you need to be assessed. Any patient who fell, so any fall, they need to be assessed at least for injuries related to the fall. Did they injure their hip? Did they injure their knee? Did they injure their wrist? Be very careful with any patient who's on antiplatelet medications like aspirin or Plavix or any of the anticoagulants, whether it's Coumadin, Eliquis, Xarelto, or any of those. Those patients are high risk for bleeding, particularly if they have a head injury. So if you're talking about what we do at the hospital, any patient who's on antiplatelets or anticoagulants with a head injury immediately goes to CT for imaging to see if they have a head bleed, even if they don't meet criteria to be trauma alert. High risk feature any patient who lives alone. So if the patient fell once, if the patient got stuck on the commode, what's the likelihood that they're going to have another event and need further care? So any patient who lives alone with no support services and no one who can check on the patient, they are high risk. And toward the end, I'll talk about some things that we could do with our patients on these lift assists for reducing risk. And I would suggest that any patient who lives alone probably should have a callback during business hours just to make sure they're doing okay. So it doesn't need to be you that does it, but maybe you need to work out a process within your department where lift assists are recontacted within 8 to 12 hours if they live alone. And then any patient who's had 2 calls in 24 to 48 hours should be high risk and probably should go to the emergency department. If you have one of your regulars that calls a couple times a week, that may be a little different than the patient who you've never heard of and now has 2 calls in 2 days. In any case, if you have frequent visits with the same patient, you should think about taking them to the emergency department. Something is not right. All right. So what do you think should be documented? So, we have a protocol as part of our documentation standard on what needs to be documented for lift assists. So lift assists require a run report, not a NIFRS report. This is patient contact. There must be a run report in either ESO or image trend. And, we need to document certain things. The reason for the call, a brief patient assessment and vital signs. And that patient assessment should be focused on the patient's complaint. If they fell, then there needs to be an injury assessment. They need to be assessed for possible stroke. If they're stuck on the commode with sudden weakness, assess for a stroke or something else. Patients who are diabetic should have a finger stick. All patients should have vital signs. We should have vital signs on our patients as lift assists. It adds a couple extra minutes, but it can keep you from getting called back or the patient have worsening problems. A basic description of the patient's condition. Are they healthy? Are they sick? Do they have any focal deficits, old or new, and so on. So, basic descriptions of condition, and if indicated by the patient's condition, a note that transportation was offered. So if you think the patient needs to go, then you should advise the patient. If they decide they don't want to go, then follow our refusal process, and you should document the patient's capacity to decline transport. Patients with capacity have the right to make bad decisions. Patients without capacity need to be provided appropriate care, and it's up to you to decide if the patient has capacity. And then a note as whether a social service agency or referral was made. So if you have patients, particularly older patients, and they call for a lift assist and they decline transport, think about whether or not a report to APS is indicated. Remember, you as a provider are mandated by state law to report to APS or law enforcement if you think the patient is suffering from abuse or neglect or otherwise bad conditions that they cannot control. So think about APS and whether or not you're going to file a report. This is kind of the algorithm out of our protocol. Does the patient require transport? Yes or no. If on the right-hand side, if the patient does not require transport, then you have to go through the review of does the patient have decisional capacity. And if the patient has decisional capacity, then patient uh, can decline care. However, if the patient requires transport and they don't have capacity, then you need to follow the process and move the patient on. If they have capacity, they can refuse care. So, that's kind of our brief guideline. So I'll keep in mind that for all of us, the standard of care is no different regardless of which vehicle is dispatched, whether it's an engine ladder or medic. The level of certification of the providers. So if you're an EMT rather than a paramedic, the standard still applies, and the standard still applies regardless of time of day. We all understand that at 2 a.m. You really don't want to be up and out to help somebody off the commode or help change their sheets, but it doesn't matter what time of day. We have to keep in mind that patients we do not transport are our highest risk patients in terms of complaints and potential for accusations of abuse or neglect. So please keep in mind, it doesn't matter what truck you're on, the time of day, or your level of certification, we have to provide an appropriate assessment for patients as part of a lift assist. Some additional comments. You as an EMS provider, you as a firefighter have an opportunity that's offered to no other providers. Patients welcome you into their home. And we'll see this with home health and community paramedics. Home health will call and ask if community paramedics will help get them in the house because if you're in your firefighter's uniform, patients will let you in. If you're a home health nurse, they'd be a little more reluctant to let the provider into the house. Also, you as firefighters and EMS providers are well tuned to scene size up. You know what's going on. You can walk in the house and you can get a pretty good idea very quickly what's happening in the patient's home and what's the patient's capacity to provide self-care. You also need to think about, is the patient suffering from neglect or abuse? And if so, that must be reported. You cannot leave that for somebody else. You individually, as a provider, are required to make or report neglect and abuse. So either law enforcement or adult protection services. How can you avoid future calls? Well, some things you can do that may help prevent future calls. You can do a quick home safety assessment and make recommendations to the patient. If you have a community paramedic available, think about making a referral to community paramedics or your community paramedic in your department. Patients can refuse the visit, but it might help them. And many patients get a lot of service and benefit from our community paramedics. You can also think about referral to home health or city or social services. A lot of that would depend on what you might have available as a community paramedic, but you don't need to have a community paramedic to have some knowledge of what services can be available and who you might call. I mentioned it earlier. Think about a revisit or a follow-up phone call. It doesn't need to be 2 o'clock in the morning, but perhaps as part of your community safety risk reduction, you can have a process where somebody follows up with the patient, somebody makes a phone call or swing past the house. If the patient is elderly and they are having repeated calls, perhaps somebody makes a revisit. If it's 2 in the morning, the patient refuses and you were really worried about the patient, perhaps somebody during daytime hours makes a revisit to the house, knocks on the door and makes sure the patient is okay. Or when you leave, let the patient know that somebody's going to call the next morning and to expect the call. So you really can benefit, the patient can really benefit by revisits or follow-up phone calls. And the last thing is leverage family members. When I have a patient in the emergency department who does not want to be admitted, the first thing I do is get the family involved. Patients will listen to their family members before they'll listen to me. Patients do not want to get their spouse mad at them, or at least like to avoid getting their spouse mad at them. So leverage the family members. If it's 2 in the morning, can you call the daughter? The patient has to say yes, but can you call the daughter either at 2 in the morning or 8 in the morning? Or if the family's already up and at the house, get them involved in the conversation, see what's going on. Often the family will give you background information that the patient isn't telling you. The patient's been deteriorating over the past week. Patient's mentation is not as good as it used to be. What the other family concerns are. So it's very important to get the family members involved if you can. So our case, the patient was assessed by engine 1001. The patient is awake and alert. She is unable to stand without assistance of two firefighters. Her blood pressure is 110 over 80. Respiration's upper end of normal. Pulse rate's up, and her temperature's 101. She's screened for strokes. Stroke assessment is negative. You check your electronic patient care record, and there's no previous runs on this patient. Well, what do you do? Well, I think this patient is sick, probably either has a infection or is septic. She needs two firefighters to get her up off the commode. Every attempt should be made to get this patient to the hospital. I don't think this patient uh, is really able to stay at home, and I would use every trick in the book to get her to the hospital. And I would really involve the family if they're available as well. This is not somebody I would allow to refuse. So in summary, lift assists represent a significant portion of our EMS and engine run volume. You all know that better than I do. The onus is on EMS providers to determine if the patient is well and does not require transport. What I mean by that is the onus is on EMS to evaluate the patient to verify that they do not have an acute condition that requires transport. So if the patient is acutely weak, or the patient slides out of bed or falls to the floor because they couldn't stand, well, maybe they had a stroke. Maybe they're hypoglycemic. If the patient simply squatted down and now can't get back up, then maybe they need less of an evaluation, but at minimum they need vital signs. So it's up to us to prove the patient doesn't require transport. You have to have an adequate assessment that is based upon the patient's complaint, and it must be documented in the run report. The onus is on the patient to prove they have the capacity to refuse. So if you identify that the patient has a reason for transport, it's up to the patient to prove they have capacity to refuse the transport. So again, EMS has to evaluate, verify there's no acute medical condition that requires transport. The patient, if they want to refuse transport, have to prove they have the capacity to refuse. And an appropriate assessment should always be performed on the patients. If you look at the runs that we've had over the past months, where we have a lift assist, a patient's not transported, then there's another run within a day or two. Most of the patients had some acute condition that was not identified on the first visit because there did not appear, based on my review of the run report, there did not appear to be an adequate assessment of the patient. Have a heightened awareness of lower threshold for transport for patients who are anticoagulated, who've fallen, any patient with abnormal vital signs, and that would include pulse oximetry, finger stick, any other vital sign that is appropriate for the patient's complaint. Basic vital signs are pulse, blood pressure, and respiratory rate. But if the patient has other vital signs that are abnormal, think about taking them to the hospital. Any patient who's acutely impaired, who's previously self-sufficient. So yesterday was fine, today's not. Went to bed fine, now at 2 in the morning are not. Those should be red flags that these patients have some acute process going on, and those patients should be offered transport. And then finally, previous list assist with the preceding 48 to 72 hours. That is another red flag. Just like in the emergency department, if I see a patient that's been in the emergency department within the past 2 days, my spidey sense goes off, and I have a much lower threshold to recommend admission to the hospital. Patients don't come to the emergency department in general twice in 48 to 72 hours because they want to visit. Same thing with EMS. Patients typically don't call EMS twice in 48 hours just because they want to see your smiling face at 2 in the morning. Something is going on. So please keep all this in mind. Have a low threshold and try to keep the patient safe and to keep you out of bad circumstances, having to explain why you did or didn't do anything. So I know this is a common complaint. I know we've talked about it recently, but again, because we have a bunch of new providers with us, I wanted to make sure we covered this topic. If you have any questions or concerns, feel free to post them on Basecamp. So that's it for me. Thank you.